Hello everyone, I'm Curtis Ray, Professor of Surgery at UT Health Houston.
Hi everyone, I'm Nirav Thosani. I'm Professor in Interventional Gastroenterology, also at UT Health Houston.
Today we're going to discuss our recent publication in gastrointestinal endoscopy detailing our initial experience with pancreatic endoscopic radiofrequency ablation for patients with resectable pancreas cancer. Dr. Thosani, how did you start performing endoscopic radiofrequency ablation?
So there is a very famous saying in interventional gastroenterology, all endoscopic innovation happens when surgeons like you don't want to do surgery. So I can recall in 2016, we had a patient who had a VIPoma and needed procedure. Patient was very sick, so obviously could not undergo surgery. And that was our very first patient. We did a endoscopic EUS-RFA. Patient had excellent response, and that led us to start doing this EUS-RFA procedures for neuroendocrine tumors, pancreatic cystic neoplasm, as well as pancreatic cancer.
Dr. Thosani, what have you learned from your EUS-RFA experience?
So I can tell you, over the last 4 or 5 years, after doing over 250 EUS-RFA procedures, this is a very safe procedure. Procedure is mostly done on outpatient basis. I can recall one patient we had to admit post-procedure, but rest of the time all patients got the procedure done. Takes roughly about 30 minutes to do the procedure. Then patients spend another hour in recovery, and most of the patients able to go home. There could be mild post-procedure pain or nausea and vomiting on some patients. About half of the patient wake up like nothing happened. And those are very easily treated with post-operative pain medications and nausea medications. So overall, I feel procedure is very safe, very well tolerated. Most patients, when we had done a repeated procedures, they have stated to me that they are able to tolerate this better than their prior radiation treatment, or even they are tolerating this better than chemotherapy. Dr. Ray, as a pancreatic surgeon, what do you think about EUS-RFA?
Great question, Dr. Thosani. As you know, pancreas cancer remains one of the most lethal diagnoses in this country. It's estimated this year that 51,000 patients will die from pancreas cancer. And over the last 50 years, we really have not made a lot of significant progress with regards to these survival outcomes. Now with this new technique and this new procedure that is minimally invasive, as you mentioned, well tolerated by patients, it's hopeful that this may be an additional treatment that we can include in our armamentarium for the treatment of pancreas cancer. And as you can tell from this recent publication in gastrointestinal endoscopy, some of these early results are very exciting as we're looking at changes in the pancreas following this ablation procedure.
So Dr. Ray, you probably have the most experience doing the surgery in pancreas cancer after EUS-RFA. Do you think RFA influence surgical outcomes?
Well, it was obviously one of our big considerations and one of our big concerns when we started embarking upon this project. It's known that radiation can influence the surgical procedure and can induce fibrosis, which can make pancreas cancer, gastric cancer, rectal cancer surgeries a little more challenging. We were pleasantly surprised to find that in our first patients that we started to perform RFA, followed by pancreatic surgery, Whipple operation, that it did not seem to influence it that much. We were still able to dissect and develop the planes along the superior mesenteric vein, common hepatic artery, and perform the standard oncologic classic Whipple operation with relatively minimal fibrosis. So far it seems to have very little influence upon the actual challenging operation.
So Dr. Ray, what do you think is most promising and exciting about EUS-RFA in pancreas cancer?
Well, one of the things that we've known and many investigators throughout the world have found is that pancreas cancer is often very resistant to standard chemotherapy and resistant to radiation. And our new understanding of that research that we've done, as well as research in other facilities, is that pancreas cancer is a very immunosuppressed environment, and having chemotherapy penetrate into the cancer and having preoperative treatment result in a meaningful radiographic response is seen in only a third of cases. And what we've been finding with this protocol, where you have been, we've been including RFA in the neoadjuvant treatment, is that we are seeing more of a preoperative treatment response. We are seeing a higher percentage of patients demonstrating an overall radiographic response and downsizing of these tumors. And this is on the macroscopic radiographic view, but even on the microscopic level, we're seeing changes in these resected specimens, and we're seeing evidence of immune cell modulation, as well as activated T cells and our immune system now penetrating into the cancer following RFA. And this really brings up a very exciting concept, which is the RFA procedure inducing immunomodulation in this otherwise immunosuppressed pancreas cancer, which really then leads us to start thinking about how we might include immunotherapies in trials for pancreas cancer. And as you know, that's an area under active investigation and planning here for our next series of trials, because I think this is a game changer. So Dr. Thosani, as the EUS-RFA procedure continues to grow, how does an interventional gastroenterologist start performing this procedure?
Great question, and a lot of interest worldwide in this procedure with our early results. As I can tell you, procedure is safe and effective, but it does require certain skill level to do these procedures. I would not advise anybody who is barely starting their journey in the world of EUS. I would advise that somebody who has at least a couple years of experience doing pancreaticobiliary EUS. Correct needle placement is critical in these procedures, and as you know, in pancreas cancer, we are surrounded by a lot of vital structures, blood vessels, pancreatic duct, bile duct, and needle placement is a key to identify areas of ablation. At our center, we've been doing this trial under IRB, under prospective registry and prospective trial, and I would suggest that as other center wants to start it, they also should do it under prospective registry, so we all can collectively learn from each other's experience and do this procedure safely.